To talk about young onset Parkinson disease and its current scenario in India, how it affects and what are the issues in relation to the young onset Parkinson disease, specifically in relation to the Indian context. As we all know, Parkinson's disease is not one symptom, it's a completely a whole tree. The symptoms which starts as a genetic proposition in the form of a seed which grows into a small plant and then a tree wherein we diagnose it. When the tree has grown sufficiently enough, we can see a bigger symptoms such as tremors, bradykinesia and rigidity, which we call it as motor classical symptoms, and that is when the diagnosis of Parkinson disease is established. Parkinson disease, as we know, it has the whole shoot system which is above the ground, which we call as motor symptoms, and there is a whole root system which we call it as non-motor symptoms, which are not visibly seen, but we need to ask them. As things evolve, as time goes by, as a tree grows, these symptoms keep on changing and leading to having multiple set of symptoms having over a period of time. And this evolution of symptoms over a period of time is the concern of the management for Parkinson disease. So we'll come to the specifically today about young but early onset Parkinson disease. Normally, we know that Parkinson disease are common after the age of 50 years. However, there are a small subset of patients who have symptoms with less than 50 years at onset. Initially, there was no clear name or terminology for this subset of patients, and they used to be called as earlier for early onset Parkinson disease. These cases have been well recognized in as early as 19th century, and as Hushard has described the first patient with 3-year-old with so-called Parkinson disease, and then in 1910, a description of 14 patients of PD with 6 being familiar or youngest being about 18 years of age. There have been various names and terminologies used over the period, including paralysis agitans juvenalis familialis, familial paralysis agitans juvenalis, juvenile Parkinsonism, early onset Parkinson's disease, young onset Parkinson's disease. The name has been aplenty as there hasn't been a consistent in explanation. What is considered is juvenile onset Parkinson disease is something when you have onset of symptoms of Parkinson disease before the age of 21 years, and young onset of Parkinson disease is before the age of 40 years. However, recently in 2022, the MDS AOS task force has come up with a early onset criteria where they have suggested that anyone before the 50 years should be clubbed under the terminology of early onset Parkinson disease. This age cutoff has been used keeping in mind about the prevalence of the disease, the geographical disease, the hormonal patterns, what changes, impact of and social perceptions related to this. Based upon that, any person who is having onset of Parkinson disease before the age of 50 years is considered as early onset Parkinson disease. So we'll take from this point as even though the term young and early are mostly interchangeably used, we'll take as onset of Parkinson disease before the 50 years at onset. So let us look into it, how India and the young onset Parkinson disease picture is there in India. If you look, there has been a great studies happening in relation to the young onset Parkinson disease, specifically thanks to the Parkinson's Research Alliance of India, which is conducting a pan-India multi-center genetic study on young onset Parkinson disease. Globally, the prevalence of YOPD, when you look into it, it's about 5 to 7%. But when you look into the Asian populations, it increases to around 10 to 14%. If you look into the global general age at onset of Parkinson disease, in India, the average age of onset of Parkinson disease is almost a decade earlier as compared to the Western populations. So most of the people will try to have around the age of 50 years as in 60 years globally. And this leads to more and more patients having earlier onset of Parkinson disease. There have been big publications which have come out on the 668 Indian subjects with juvenile, young and early onset Parkinson disease. And the clinical understanding, even though the classical epidemiological studies are not available, the based upon what you call it as clinic-based studies and other studies, there has been prevalence of young onset Parkinson disease is well acknowledged in Indian context and definitely quite higher based upon these studies. So, what are the clinical features of this young onset Parkinson disease? If you look into the classical understanding, what we have is Quinn et al. In 1987 had told that young onset Parkinson disease have more of akinesia and rigidity, less frequently tremors. Gibbs et al. Have also told that there is more often rigidity and more frequent of dystonias. However, the first important major publication of young onset Parkinson disease came by Dr. Mutane et al. In 1994, who had noted that all patients with young onset Parkinson disease had tremors at presentation. And subsequently, later by Mehna et al. In 2014, it is noticed that tremor appears to be as a predominant symptom in early onset Parkinson disease. In our own publications of the young juvenile and early onset Parkinson disease, tremors contributed to about 75% of the patients. So what we can notice that even though earlier understanding that akinesia and rigidity are commonest presentation with less frequency of tremors, the usual notion is of mostly of akinetic rigid may not be the pure accurate perception. It can have a regular Parkinson disease type of a presentation with tremor prominence can be seen. If you see the Indian cohort with young onset Parkinson disease, what you can see is when you look, divide them into juvenile onset, young onset, and early onset Parkinson disease, dystonic symptoms are more commonly seen in juvenile onset Parkinson disease, or gait impairment is more commonly seen in juvenile onset Parkinson disease. And in young onset Parkinson's disease, primarily more gait issues are noticed. And this is what is the difference in the motor symptoms, what we look into go from the juvenile onset, young onset, and early onset Parkinson's disease. When we looked into the non-motor symptoms in this subset of our Indian young onset Parkinson disease, the juvenile onset, that is those who had onset of Parkinson disease before the age of 21 years, had more commonly anxiety, panic attacks, depressions, sleep issues, but sleep issue was less common in this group. Young onset Parkinson disease, those between 21 to 40 years, commonly had more depression and sexual dysfunction, reflecting their family life and other social life. And then early onset Parkinson disease, those who had onset of symptoms after 40, between 40 to 50 years, they more prominently had more of REM sleep behavioral disorders and bladder issues were commonly noticed as non-motor symptoms in these three subgroups. So what you can see when you look into different age cutoffs in our early onset Parkinson disease in India, you can see that young onset Parkinson disease had more consanguineous parentage, more frequent dystonia, gait impairment, balance issues as compared to the early onset. Depression and sexual dysfunction are more common in young onset Parkinson disease. RBD is less common in YOPD versus EOPD. Dyskinesias frequency, what we noticed, was higher in YOPD versus EOPD. However, these people also had longer average duration of symptoms to develop dyskinesias in YOPD as against EOPD. It just shows that longer survival ability in these patients and the development of dyskinesias down the time. Now, let's look into what are the genetic factors which affects the Indian YOPD patients. There have been two important publications on genetic factors of Indian YOPD. One is the genome-wide polygenic risk scores and genome-wide polygenic understanding. Then second is genetic drivers of the juvenile, young and early onset Parkinson disease in India, which has both have come from the GOPI YOPD project of the Parkinson's Research Alliance of India. Herein, we have noticed that there has been high rate of consanguinity, especially in South India, hence probably more likely autosomal recessive disorders commonly you may see in Southern India. Most of the time what we are seeing the higher frequency of monogenic forms such as Parkin mutations, PINK1 mutations, VPS13C mutations, and all these patients definitely would require genetic testing and counseling, as lot of these can have the change, the rate of progression, response to therapies can vary in this subset of patients. Let us now look into the socio-economic impact of having and early onset Parkinson disease. The most important, because this is the age group when people are employed, working, they're starting their family lives. It has significant effect on their employment. Sometimes people do take early retirements. Family planning is an issue. Sometimes the discordance in the family can develop just because of the problems. Social lives are affected because people don't want to interact and talk to other people because their diseases becomes more issues and they become more and more withdrawn. And naturally, because of these problems, especially the spouse or the partners will have more caregiver strain, and most of the people being in their early financial stabilization phase, the finances become another issues having a great impact in this subset of patients as against to the late onset Parkinson disease, where most of these are usually addressed and have been fairly stabilized in their life. In addition to socioeconomic status, we also have issues in relation to cognitive and psychological challenges such as depression, anxiety, panic attacks, and cognition. These symptoms becomes, as you can see that, as I showed you, juvenile and early onset, young onset Parkinson, they have commonly more depression because it's related to their professional life in addition to the add-off of these symptoms. How to manage? Is there a specific management or how can we manage these patients? Initially, it was noticed that the response to therapies, the standard dopamine therapies, Quinn et al. Told that dyskinesias and motor fluctuations were more frequent and earlier in these patients. However, there was no correlation between the duration of disease before instituting levodopa. Early morning off dystonia and sleep benefit was more common in subset of disease. However, when the same group extended series was published in 1998, they noticed that more than 25% had developed dyskinesias with levodopa within a week of initiation, and approximately 40% had levodopa-induced dyskinesias within 6 months, and 91% by 5 years of treatment. This had led to a notion that YOPD and early onset Parkinson disease are very sensitive to the levodopa-induced dyskinesias. However, when we look into the Indian subset of patients, what we noticed are about one third of our patients had developed dyskinesias, with the average duration of symptoms at dyskinesias being around 5.4 years. And this varied from yes, less than 1 month to up to 18 years. We could also notice that juvenile onset Parkinson disease patients had noted a development of dyskinesias after about 9.6 years of onset of symptoms, and most commonly they had dystonic dyskinesia. Please note dystonic dyskinesias because this is more painful and uncomfortable dyskinesias. Our young and early onset you can see that young and early onset had about 40 and 25%, and they develop after about 5.7 years and 4.4 years of it. So what you can see that earlier onset probably having later development of dyskinesias. As time goes by, as later and later, the development of dyskinesias can become earlier and earlier. We also looked into the response to therapy among various publications. What you looked at when Mehna et al. From US, they looked into the early, middle onset and late onset Parkinson disease. The frequency of dyskinesia and dystonia was lower with increasing age at onset. Professor Mutane's paper had shown that 50% of YOPD and 33% of GOPD developed dyskinesia at the end of 6 months of therapy. And Dr. Kumar's paper in 2005 looked into 40% had developed dyskinesia at 5 years of levodopa therapy, and we had noticed around one third of the patients. So YOPD and DOPD might have dyskinesia pattern closer to regular onset Parkinson disease. However, small subset of YOPD develop more disturbing and early dyskinesias, mostly dystonic in character, which leaves a long lasting impression in our minds that they are more common and more uncomfortable. How do we manage? What we have seen, most commonly the early onset Parkinson disease have more polypharmacy. This comes out of our paper on levodopa equivalent daily dosages, which was done including about 10 centers globally with 4 centers from India. What we noticed that Indian and Malaysian patients invariably tend to use Indian and Thailand patients, or sorry, not Malaysian. Indian and Thailand patients, these are the two countries, had more polypharmacies, especially those between the 40 to 50 years age group. And probably higher levodopa equivalent daily dosages in this UOPD group, and non-levodopa component means using of dopamine agonists, using MAOB inhibitors, amantadine, or any newer therapies was quite common in this early onset Parkinson disease group. So please do remember, people tend to try multiple medications in this because they are the working group. They want to see how best they can come. They want to see how easily they can manage, and they end up most commonly with a polypharmacy in this subset of patients. So what special needs these patients need? They require they require specifically tailor-made approach with genetic counseling, why they have developed, what risk factors they have. And some patients would definitely be benefited by vocational rehabilitation to understand and how to manage their work. Family counseling is very critical because this is the crucial part of their life, and proper understanding partners and support system will definitely take a long way to have better productivity and better management. And social support plays very critical role in, especially in young and early onset Parkinson disease. When you talked about productivity and quality of life, there is an association. YOPD is associated with significant poor quality of life. There are a lot of marital conflicts, social isolation, occupational difficulties, and non-motor symptoms profoundly affect these patients' quality of life. And this has to be, we need to make sure that whenever they come, given more attention on their non-motor symptoms, ask those specific questions to see what can be addressed on. India, what do we have? Our own unique challenges. What we notice is there's late recognition and diagnosis due to lack of awareness. Initially, many times people end up with various different subspecialties and not getting a right diagnosis, and then limited access to genetic testing and specialized care and rehabilitation. There are a lot of cultural stigma also, and economic barriers because people don't want to tell that they have a Parkinson disease or someone else in the family have Parkinson disease, because there are various limitations in the family relation to announcement of Parkinson disease. So this cultural stigma has to be overcome. So what can we do for our Indian patients? We need to create more public awareness. Inform about the importance of recognizing Parkinson disease, and which can be fairly well treated, where people can have good quality of life. We need to have more and more specified dedicated clinic where people feel that yes, someone is trying to address their issues and we are not clumped together everyone else, where priorities vary from person to person. Genetic screening is required to understand more about Indian sub-cohort of Parkinson disease so that treatment goals can be achieved. And we need to create more advocacy groups so that specific regulations, governmental help for these patients with young onset Parkinson disease can be established. In this, we need to have more integrated genetic and clinical research programs like the Parkinson Research Alliance of India is doing with various risks. Polygenic risk scores for early predictions and interventions could be useful, and leveraging technology for remote monitoring and telemedicine solutions helps to support and improve a lot of patients with Parkinson disease. Thank you. Before I end, we should remember about the unique challenges, tailor-made therapy, multidisciplinary approach, and proactive care. Thank you. Thanks a lot. Any questions, please feel